Let us know about the scapulohumeral rhythm. The scapulohumeral rhythm is contributed to the abduction above 90 degrees. So the coordinated movements of scapula and humerus increasing the range of motion at glenohumeral joint is scapulohumeral rhythm. And this noticeably is seen during complete flexion and abduction of the shoulder. It is always in the ratio of 1:2, where the scapula is moved about 1% and the humerus moves about 2%, or 1 degree movement of scapula is contributed by 2 degrees of movements of the humerus. So in 2 degrees of humeral abduction, it is associated with 1 degree of scapular rotation. For example, in 180 degrees motion, the abduction of the humerus is about 120 degrees and the scapular rotation is about 60 degrees. So it is always in 2:1 ratio of humerus to scapula during abduction. So that is every 15 degrees of elevation, 10 degrees occur at shoulder joint and 5 degrees by the scapular movement, that is the rotation of the scapula. So this is again the same abduction, again 0 to 15 degrees. It is initiated by the supraspinatus, which is taken over by deltoid till about 90 degrees, and the major abductor is between 15 to 90 degrees, and the overhead elevation, that is to 180 degrees, is brought about by the rotation of scapula contributed by upper and lower fibers of trapezius and the lower 5 digitations of serratus anterior. So these are the prime movers, and this is how the rotation is contributed by the upper and lower fibers of the trapezius and the serratus anterior. All this contribute together as scapulohumeral rhythm. Coming to the radiological part of the shoulder joint, how it appears on the scaiogram. So if you take the chest x-ray or the shoulder joint in proper, we'll be able to see the head of the humerus, a very shallow glenoid fossa. There's the acromion process, the coracoid process. This is the clavicle, okay. This is the medial border of the scapula, the lateral border of the scapula, okay. And these are all the ribs. So this is how the sciogram depicts of the shoulder joint. Coming to the applied aspect, what can go wrong with the shoulder joint? Shoulder joint dislocation is one of the most common feature, of which there can be anterior dislocation where the head moves forward. There can be posterior dislocation where the head moves posteriorly, and there can be inferior dislocation where the head moves inferiorly. And this is the most common type of dislocation, as there is laxity of the fibrous capsule inferiorly. We said that it is about 1 centimeter below the margin of the glenoid cavity, encroaching onto the surgical neck of the humerus here laterally. So that is the reason there is a pouch of the fibrous capsule here. So that is where the dislocation is usually inferiorly which occurs. So the dislocations are common due to laxity of ligaments and disproportionate articular surfaces, which can happen during development and during injuries. And inferior dislocation is more common, and as the axillary nerve is related inferiorly to the shoulder joint in the quadrangular space, as we said, is liable for damage in inferior dislocations of the humerus. So radiologically you will find that the head of the humerus is below the glenoid fossa. So in posterior dislocation, when the head moves posteriorly, the contour of the shoulder is shallow anteriorly. There is an elevation that you can see posteriorly, and the patient comes with pain at the shoulder joint. And in the skygram also, the head of the humerus you can see is displaced posteriorly. In anterior dislocation, the head of the humerus is displaced anteriorly, and there is shallowness in the contour of the shoulder posteriorly, and patient complains of pain. And in radiologically too, the head of the humerus is seen displaced anteriorly away from the glenoid fossa. In inferior dislocation, which usually occurs due to violent abduction, where the head is displaced inferiorly, injuring the axillary nerve as well, and there can be seen as a lump in the axilla when the arm is abducted. You can see a swelling in the axilla. So this is how the dislocations can be seen. And then there's another condition called as painful arc syndrome. It is a clinical syndrome where pain in the shoulder and upper arm is seen during mid-range of abduction. This painful arc syndrome can be due to subacute supraspinatus tendinitis, calcification of supraspinatus tendon, or subacromial bursitis, or greater tuberosity fracture. So whatever is there in the superior aspect of the shoulder, or the structures that are beneath the coracoacromial arch, when there is any pathology with this structure, then there will be painful arc syndrome, because the supraspinatus is the muscle which initiates the abduction, and if there is any tendinitis or calcification, then the subacromial space is decreased and there will be impingement of the supraspinatus muscle to the subacromial arch, which would cause pain during the abduction beyond 60 degrees, that is between 60 to 120 degrees, mid-range abduction. And this can also result from the attrition of the tendons. There is gradual degeneration with wear and tear, or inflammatory disorders such as rheumatoid arthritis, where there is constant movements that are seen, like in athletes, the cricketers who bowl and use more of abduction movements. So the painful arc is seen between 60 to 120 degrees of abduction and indicates the pain which is arising from subacromial region. So which is within, if the pain, when you ask the patient to abduct his arm and if he feels pain in this range of abduction, the pathology is beneath the acromion process, that is beneath the coracoacromion arch, which can be due to all these structures. And if the pain of motion is seen between the at the end of 180 degrees, that is 170 to 180 degrees abduction, that indicates the pain is from the acromioclavicular joint, which may be due to arthritis of acromioclavicular joint, where the pain is felt at tip of the shoulder, because that is where we can feel the acromioclavicular joint as well. So arthritis of acromioclavicular joint will cause the pain in the abduction at the end of the arc, that is from 170 to 180 degrees. When the patient is feeling pain there, then there is something wrong with the acromioclavicular joint. So this is what is the painful arc syndrome. So from 0 to 160 degrees and from 120 to 180 degrees, there won't be any pain if the pathology is below the coracoacromion arch. It is the mid-abduction pain only is felt. That is because of the pathology mainly to the supraspinatus muscle and subacromion bursitis, and of course the greater tuberosity fracture as well, where the rotator cuff, few of the rotator cuff muscles are inserted onto the greater tuberosity. And if the pain is felt at the 170 to 180 degrees, at almost at the vertical part of the elevation of the hand, then the pathology is at the acromioclavicular joint. So calcific tendinitis of the shoulder. So calcific tendinitis of the shoulder may be acute or chronic. Acute means sudden. Chronic means it is there since long time and depicts in a later stage. It is a painful condition due to the presence of calcium deposits inside the tendons of rotator cuff. More specifically, it is seen in the supraspinatus tendon and a little more less frequently in infraspinatus tendon. So these calcifications are seen about 1 centimeter from the insertion of the supraspinatus tendon. This space, the 1 centimeter proximal to the insertion of supraspinatus tendon, is called as critical zone. That is where the calcifications are seen, and that is the area where it can get impinged onto the lateral border of the coracoacromion arch, causing pain in the mid abduction range, that is from 0 to 120 degrees. From 0 to 60 degrees, the hand is not elevated or hand is not abducted so much that the supraspinatus can get impinged onto the lateral border of the coracoacromion arch. But beyond 60 degrees, when it is abducted, there is all possibility of this supraspinatus tendon getting impinged onto the lateral border of the coracoacromion arch to cause the mid-range abduction pain, which is called as painful arc syndrome. And these can be detected radiographically as the calcium deposits nearer to the greater tubercle at the critical zone of the supraspinatus, which is about 1 centimeter proximal to the insertion of the supraspinatus tendon. And these can be cured by giving painkillers or cortisone injections, or these can be removed also by ultrasound guided removal or shock wave therapy. You can just break down these calcium deposits. They are nothing but hydroxy epoxy crystals, which are seen in cartilages also. So these calcific deposits can be broken down by the shock wave therapies also. Glenoidal labrum tears. So these are the glenoid labrum tears. If it is at the supraglenoid tubercle, it is called as slab tear, which means superior labrum anterior to posterior tear, anterior to the posterior tear. And there can be a tear antero-inferiorly, which is called as Bancart's lesion. This usually occurs, as we said, that there is laxity of the fibrous capsule lower down in the inferior aspect. So if there are frequent subluxations, that is slipping of the head of the humerus inferiorly, there is a pocket that is created within the labrum, where the labrum also becomes little loose and lax, and with gradual repeated movements of abduction, the tear can happen, which is called as Bancart's lesion. And then into this Bancart's lesion, into this pocket, the head of the humerus sits when it dislocates anteriorly during violent abduction movements. So to differentiate between these two tears, the slab is usually at the site of the biceps tendon attachment, and the Bancart's is located antero-inferior and shifts towards the front of the body as anterior labial tear. It extends anteriorly. And this is very common with athletes with shoulder instability and results in very painful movements at the shoulder joint. There can be rarely the lateral tears also, because the rotator cuff, which is blending with the fibrous capsule, also has intimate contact with the glenoid labrum, which is attached onto the periphery of the glenoid cavity. So these are very rare, the anterior and posterior, the lateral tears. These are called as lateral tears. They are very rare, and slab tear and Bancart's lesions or the Bancart's tears are very common. Springly shoulder. Springly shoulder is known as high scapula. It is a congenital anomaly where the descent of scapula is not properly occurred to its anatomical position. So that person has one shoulder blade which is sitting at a higher position than the other normal shoulder blade. So whenever there is such type of irregularity of the positioning of the bones which are not in anatomical position, the movements are very much compromised at their particular joints. So the abduction of the limb, this is the normal side, this is the abnormal side, that is the springly shoulder where it is there. So the overhead abduction is normal on the normal side, whereas it is very much restricted to about say 120 degrees in the springly shoulder side. So this abnormal caudal migration or the failure in caudal migration of the scapula may be due to the presence of omovertebral bone or spinoscapular lineage. So this can be treated wherein there will be orthoscopically the omovertebral bone is broken and the scapula is descended down, correcting the position of the scapula. So now coming to the rotator cuff injuries. These happen usually due to the overusage of these muscles or by the acute injury, which can be due to road traffic accidents, falling on the shoulder or falling with an outstretched hand, which can strain these muscles initially, and if the same overuse is repeated with these muscles, there will be a tear that can be seen in the rotator cuff muscles nearer to its insertion. And the tear can be partial or complete. And they are usually seen in athletes, particularly in tennis players, swimmers, wrestlers, rowers, players, wherever there is abduction, the more of the movements are seen at the shoulder joint, the violent movements can be at times, there can be violent movements. When a tennis player gives a shot, it is a bit of violent movement that happens, the abduction that happens at the shoulder joint, and the overuse of that same movement can cause strain basically in the joint, and if it is repeated, the overusage of the same violent movements can cause tear. So that can be due to rotator cuff tendinitis when there is any inflammation in the tendons, when there is shoulder bursitis, when any of these bursa is inflamed, which most commonly is the subacromial bursa, and which will lead to tear because of the overusage, and that causes pain at tip of the shoulder. When such type of things happen, the abduction of the limb is very much restricted. There is a painful abduction, which also can be put in a part of painful arc syndrome and can be rectified by approximating the torn edges and stitching them together orthoscopically. Coming to the tendinitis of rotator cuff, which can be called as a frozen shoulder or adhesive capsulitis. This is a normal capsule of the shoulder joint. When there is any inflammation of the shoulder surrounding structure, that is, the inflammation can be of the rotator cuff tendons or the bursa, which in turn will lead to the infections, and once they are healed, they form a scar tissue which can cause contraction of the fibrous capsule, which is called as the frozen shoulder or the adhesive capsulitis. So there can be scar formation, means thickening. So once this laxity is lost of the fibrous capsule, which is blended by these rotator cuff tendons, the movements of the shoulder joint are very much restricted. Because of the laxity of the fibrous capsule, the movements are more competent with the shoulder joint than any other joint. So when there is fibrosis of the fibrous capsule, that is the thickening of the fibrous capsule happens, the laxity of the fibrous capsule is lost and the movements are very much restricted at the shoulder joint. Coming to the last rescue, that is the shoulder replacement. When nothing can be done surgically or treated properly, then the articular surfaces have to be replaced by prosthesis to enable the patient to perform his day-to-day activities or the movements at the shoulder joint. So the replacement of the articular surfaces is called as arthroplasty. So these can be replaced by artificial implants to restore the range of mobility at the shoulder joint, successfully treating the severe pain and stiffness that the patient is seeing all through the time. So this replacement can be partial, which we call it as hemiorthosis or hemi orthoplasty, or total when it is called total orthoplasty. We'll see what it is. So the artificial implants, which will be replacing the damaged articular surfaces, which can be due to bony spurs or mainly due to arthritis, they are called as prosthesis. And these total replacement is considered when a patient has osteoarthritis, that is degenerative joint disease, or rheumatoid arthritis, post-traumatic arthritis, or very rarely failed previous shoulder replacement surgery. That can happen when the prosthesis is loosely implanted or the prosthesis itself has been dislocated from its normal position. So this is how it is seen when only the head of the humerus is replaced or only the glenoid fossa is replaced. It is called as hemi orthoplasty. When both the head of the humerus as well as the glenoid fossa are replaced, it is called as total orthoplasty. So to replace these prostheses, first the stem is being inserted over which the ball of the head of the humerus is inserted and the glenoid component is also placed. So this is what is all about orthoplasty, to regain the movements to the patient. So that's the end of it, and this is the thought of the day. Decide, commit, and succeed. Nothing can stop you from success once you decide to do something and be committed to what you have decided, then success is definitely yours. Good luck. Stay safe.